There's a substantial capacity problem in the hospital eye service, in secondary care, and a great opportunity, as has already commenced really, for primary care optometry to be more engaged. And I think increasingly it's become something that is much more pressing than ever before. It's time for us to think a little bit more about the patients that we don't see or that we see too late. And we're worrying about all the patients we do see and being able to accommodate them. And I realize I'm going to make that a lot worse by suggesting we need to detect more glaucoma. But I think this sort of glaucoma that many of these people have is potentially very problematic. Late presentation is problematic. I'd like to see an ability for primary care optometry to be economically viable in areas of deprivation. I'd like to see a sense in which people who are in a disadvantaged background feel that they can go along and get an eye examination on a regular basis. I'd like to see some dispelling of the myths around availability of free to them sight testing, and to see a sense in which the primary care optometrist is seen as that first port of call, whatever your level of affluence, so that we don't have a scenario where people present late because they haven't been to their optometrist, for example, for 10 years, and suddenly they're pitching up with a potentially blinding condition, and they straight away need a surgical solution versus something that would have been far less complex had they had their eyes examined, had they presented to primary care years earlier. There is that issue of the facilitating primary care optometry to be viable in economically deprived areas, but I mean, you could see a more innovative GOS model. I don't have all of the answers here. I would like to see some comparisons being made between GOS as it works in England, as it works in Scotland and Wales, and seeing if some of the changes that we're seeing in Wales and Scotland over time are introducing a variation in some of the problems that we're seeing elsewhere in the system. But it seems to me essential that the fee is at a sufficient level to allow an optometrist to be able to undertake their work without feeling the need to derive income from, if you like, the optical appliance. And this has always been a problem, but it continues to be a problem for patients from a perception point of view. And it'd be really important, I think, moving forward, that some strong attempts are made to not leave us in another 10 years' time doing a similar evaluation and finding, actually, do you know what, things haven't changed at all. Already I look back 10 years and we look at the work of Darren Chickle and colleagues, and looking today, it still feels there's a stark difference. And I would like to see a situation where those that know more about contracting, about the GOS and so on, can effect changes in the system so that we don't see those stark differences in the future. Downstream, we see more anecdotally the cases, actually. So we can look at the research, we can look at the recent work from David Crabb showing there's still a strong link between the advanced stage of visual field loss and deprivation at those presenting for care in the hospital eye service. So individually, as clinicians, we will see patients and suddenly you're seeing somebody in their 50s and 60s and they've got bilateral significant visual loss. There may be issues about driving, there may be issues about their livelihoods, and there are certainly issues about their care. They may need to go down a surgical route rather more rapidly. So from a healthcare resource perspective, suddenly they're a case that's going to require multiple attendances. And so the economic consequences of that to them as individuals and to society potentially quite considerable. What can we say about monitoring challenges and opportunities? I think there has to be this longer term vision and responsibility to improve capacity. And for me, I think the biggest issue has to be for people not to be throwing stones from various positions, various silos. It is about collaboration, it is about integration, it's about people recognizing this problem cannot be solved using traditional measures. So people need to show the spirit of collaboration here. And that needs tenacity. It really, really does. There's no quick, easy fix. So if you're a senior clinician working in a hospital, be it an optometrist or a consultant, you can't wash your hands of these things. You've got to dig in and be in it for the long haul and establish those relationships and work towards joint management of local populations with this pressing need. Digital connectivity is really important because in the end, most hospitals now are moving to electronic patient records, have moved in that direction. Most primary care optometrists, be it the referral platform or their own records, rely on a digital interface. Things work differently in the different nation states. We've got a different arrangement in Scotland, a different arrangement in Wales, and I'm not an expert there. But for example, in England, in the past few years, we've had an ability for primary care optometrists to use a referral platform, to refer using specially developed IT, specially developed software. And this needs to be connected with the NHS architecture. There needs to be a sense in which there is that interface, because these patients are, if you're a certain risk strata for glaucoma, for example, you won't necessarily stay at that level. You might need to move back and forth. Maybe you need a visit back in the hospital. Maybe you need to be seen permanently back in the hospital. Potentially a patient that was seen in the hospital can be discharged back out to primary care. And so it's really vitally important that that exchange of information is facilitated. And the technology is probably there in some areas, and moving there in others, and a long way off in other areas. But it is definitely something, that connectivity between at the interface between primary care, between secondary care is vitally important, really. We need to think about people who are not presenting for eye examination. Because these become the people who present very late, and there are significant issues, I would argue, there. We talk a lot about equality, but we don't talk a great deal about inequality, or as much as we should, at least. People have found screening over time to not be cost effective, which is why we don't have a national screening program for glaucoma. You could potentially target those most at risk, so there could be avenues through general practice, through using other networks. So I think there is mileage there, but I don't know that anyone's come up with what the perfect system might be there. So I think it's a good idea that we do continue to explore other avenues for avoiding this sort of late detection. There is in optometry and ophthalmology a reasonable focus on capacity, a reasonable focus on referral accuracy, and indeed a reasonable focus on monitoring. But what do all of these monitoring schemes and glaucoma repeat readings and enhanced case finding schemes do for the undetected? Actually, probably little. So PEGS is a scheme where patients with relatively low risk with a glaucoma-related diagnosis like ocular hypertension or glaucoma suspect, instead of attending secondary care, instead of attending the hospital eye service to be looked after, have their appointment for monitoring done in the community setting. So it's primary eye glaucoma scheme, or service if you like. So the PEGS pilot was a scheme where in Manchester we wanted our trained and accredited primary care optometrists who'd hitherto been working in referral filtering, in fact in a glaucoma enhanced case finding program. We wanted them to participate in a scheme with us at Manchester Royal Eye Hospital where we had a selection of cases that were relatively low risk that were then able to be seen in a community setting. But because it was a pilot, we were keen that it was evaluated properly. So we've had quite a bit of emphasis on speaking to the patients, speaking to the registrant optometrists, and actually quantitatively looking at the decisions that were made and seeing in secondary care, what decision would be made by a reference standard consultant, if you like, and making comparisons. And that's allowed us to comment really on the safety of the scheme. And it's all fairly positive stuff, actually, in terms of that. There are always issues about these sorts of schemes. We did have one or two patients who were questioning the retail environment, but the vast majority were actually really happy to be seen in that setting, finding it much more convenient to attend locally. And I was particularly struck by the evaluation we did on carbon emissions, because although people talk about these things, there's very little quantitative evidence around it in terms of optometry. And so it was actually really helpful to do an analysis to show that there was that 1/3 of carbon emissions when patients were seen in primary care versus the equivalent service being provided, in the hospital eye service. And I think that's an important point, and yet another reason why delivering these services in primary care is a great idea. So it was actually the Paul Spry Memorial Lecture. It truly is a great honour to be asked to give this talk. Paul Spry has a fantastic legacy to the profession, or leaves a fantastic legacy to the profession of optometry, and it's a wonderful opportunity to remember Paul and to remember his contributions in a subject matter that was very much something that Paul would, I think, approve of. So, remembering Paul, so it's 3 years ago that we lost Paul suddenly and unexpectedly. And I'm going to start with something personal by saying I miss this chap terribly. I think you'd expect me to say that. And I hope throughout this talk, though, I'm going to sort of highlight some of the many things that he was engaged in, involved in, because optometry and glaucoma really are very intimately linked across a number of different issues, really. Paul was a wonderful friend and an outstanding colleague. He was very, very talented clinically. He worked in glaucoma, he worked in the emergency eye care. He also did visual electrophysiology. So he really was something of a polymath, because outside work, you know, he would be almost had a small holding, he would be dealing with his sheep, he was a musician. And he was a super friendly, charming chap, and he's terribly missed by many, many in the profession. But he does have this outstanding legacy that he's left the profession in terms of their interface with glaucoma in particular, and I think he deserves a fantastic accolade for those reasons.